Welcome back to Student Nurses Success. So today we're going to talk about dysrhythmias, also called arrhythmias. You can actually use those two terms interchangeably. When we talk about dysrhythmias or arrhythmias, we're really talking about a cardiac rhythm abnormality. And this abnormality affects the impulse generation or the conduction. So really what we're talking about is an electrical event. Often, dysrhythmias or arrhythmias indicate underlying pathophysiologic disorders of the heart. So it's usually caused by something else. The most common etiologies we see are hypoxia, such as when you have a myocardial infarction or a heart attack where the heart muscle doesn't get enough oxygen. Electrolyte imbalances, specifically alterations in potassium or calcium, can cause arrhythmias. Too much calcium, too little calcium, too much potassium, too little potassium, either of those are going to cause arrhythmias. Trauma or damage to the heart from something like an MI, where maybe some of the heart muscle tissue dies and alters conduction. Inflammation of the heart can cause arrhythmias, such as pericarditis or some other type of maybe endocarditis or inflammation. And drugs. Some prescription drugs can cause heart arrhythmias, and also illicit drugs like cocaine. Those can cause arrhythmias. When we talk about the pathophysiology behind arrhythmias or dysrhythmias, one of the problems is that even though we may actually see a heartbeat on the EKG, you need to realize that in some arrhythmias, the heartbeat may not be perfused, and it may not actually result in a mechanical contraction of the heart. Now, when we're talking about this particular conduction, that is a normal conducted heart rhythm there or heartbeat. So that one would likely produce cardiac output. But as we start talking about some of these arrhythmias today, things like ventricular tachycardia or ventricular fibrillation, those are not going to result in a mechanical contraction of the heart, and it's going to alter the amount of cardiac output that happens. Now, with the heartbeat, remember the normal pathways. Your heart actually comes down through the conduction pathway. It starts in the SA node and it actually filters down through the intranodal pathways, and then it hits the AV node right here, and then it goes through the bundle of His and down into the Purkinje fibers last. And so when we see this electrical activity, it actually travels all the way down through the heart. And that's how the normal electrical activity should travel. However, if there's a distortion or there's damage to the heart, then it may not run down that normal conduction pathway. So there we have the main causes or the main pathophysiology of what's going on with some of these altered heart rhythms. One thing can happen is failure to repolarize the cardiac cells. So once the cardiac cells produce a heartbeat or they produce an electrical activity that should produce a heartbeat, they have to repolarize so they can do it again. And sometimes if there's ischemia or hypoxia, they will not repolarize. And if they do not repolarize, then they're not ready to make the next beat. Sometimes it can be a triggered event where the impulse is generated too soon. Maybe there wasn't enough time to repolarize, and so it didn't fully repolarize, and that can cause an arrhythmia. Or sometimes there's an electrolyte disturbance and they're not able to repolarize. The third cause can be an ectopic pacemaker. And what we mean by that is that there is a beat or an impulse generation that is coming from the wrong location. And so it starts here and travels up and down, and that can cause, or sometimes it can start somewhere else. The fourth cause is conduction issues. Sometimes impulses get delayed or slowed as they move down through those pathways. So if there's damage in the heart here, that can delay or slow the conduction down and stretch out the actual picture of the heartbeat on the monitor. So when we're talking about manifestations of dysrhythmias or arrhythmias, our biggest concern is that if the electrical impulse doesn't produce a nice, strong, normal mechanical beat to the heart, it's going to impair the cardiac output and likely blood pressure. So you're not going to perfuse. That's really our kind of point at which we determine if we need to treat the arrhythmia. If you're having a mild arrhythmia and it's not causing any problems to cardiac output or blood pressure, they may choose not to treat it. But if it's making you fatigued or dizzy or short of breath or causing you to faint, or it's going into a lethal rhythm, such as VTAC or VFib, then for sure they're going to treat it. Let's talk a little about EKG. The EKG is a graphical recording of the electrical activity of the heart. So the electrical activity is actually being drawn out on the EKG. So it generates a picture of the electrical current that the heart generates. Now there's three lead EKGs and 12 lead EKGs. 12 leads include 6 limb leads and 6 chest leads. And so this picture right here, it shows you the placement of the leads when there is a 12 lead EKG. A 12 lead EKG is fabulous. And this is actually what it looks like. These are not separate lines. These are actually all going on at the same time. And so you're seeing 4 pictures of the same heartbeat going on. And in fact, it actually runs through the different leads. And you'll see, you can't really see it in this picture, but on a 12 lead, these are naming the different leads that correspond over here to each of these. And so it gives a picture of the heart rhythm. Now, the 12 lead is diagnostic. And so it's going to tell you if you have an actual arrhythmia. And that's what a cardiologist would order and read. The problem is that this is to be hooked up to all these leads, you wouldn't be able to ever move. And so it's really not something that we can leave someone on a 12 lead EKG continuously. So it's usually only giving us a minute or so of a picture of the heart. Our 3 lead EKG is what you're thinking of for continuously monitoring in the acute care setting, such as the hospital. However, it only provides one view. And usually a 3 lead has just 3 leads on the body. It's usually 3 of the limbs. So maybe this lead, and down here. And that will give us a nice continuous picture of what's going on. So now let's talk about counting the rate. This paper is very special that the EKG is on, and these boxes actually represent time. The tiniest of boxes here actually represents 0.04 seconds of time. And 5 of these tiny boxes, or this, actually represents 0.20 seconds of time. So to count the rate, certainly if an EKG is running either a 12 or a 3 lead, it's probably counting the rate for you. But if you pull a strip and then you have to look and see what the rate is, you can figure it out by counting these boxes. Usually what I do is find 2 spots. You can do maybe P wave to P wave and count within there. Or sometimes it's easier to do QRS to QRS and count the boxes within there. And that gives you the time between one beat. And from that, you can actually determine the rate for a minute. There's a couple ways to do it. You can take 1500 and divide it by the number of tiny boxes between these 2 points, or take 300 and divide it by the number of these larger boxes between the 2 points. And all of that gives you the rate per minute. Let's review the parts of the EKG waveform. They do mean different things. You have the P wave, which is right here. You have the PR interval, which is for the P wave all the way to the R wave. So that is right here. You have the QRS complex, which is this kind of the big uppy downy thing here. And then you have the ST segment, which runs from the ST all the way to the T. Now, there are specific times that you need to know with regard to these. The PR interval should be between 0.12 and 0.20. So it should be somewhere about 3 to 5 of the tiniest of boxes. The QRS complex is 0.04 to 0.10. So it really should be maybe 1 to no more than 2.5 of the tiniest of boxes. The ST segment is going to vary with the rate, so that one won't be a consistent number. For every normal heartbeat, you should check, and there should be a P wave for every QRS, every single time. You should also measure the PR interval and make sure that it's within normal. And you should also measure the width of the QRS complex and make sure it's normal. Now, the ST segment, it does vary with rate. The reason I bring it up here is that with ST elevation, if that ST segment is raised up higher, meaning it's appearing elevated or up higher on the EKG, we are concerned about myocardial ischemia and possibly a heart attack, also known as a STEMI. The last thing before we get started on our arrhythmias is I'd like to talk about normal sinus rhythm. You absolutely need to know what normal sinus rhythm looks like. You can't identify abnormal rhythms if you don't know what the normal rhythm looks like. Right here is a nice example of normal sinus rhythm. As far as what you're looking for is you're looking to make sure there is a P wave every time there's a QRS, PQRS, PQRS, PQRS. We have to check the length of the P wave to make sure that it's between here and it's between 0.12 and 0.20. The QRS is very tiny. It's hard to see on this picture, but it's between anywhere from 0.04, 0.06 to 0.10. And the rate is 60 to 100. The rate, again, we count all the boxes between these points and can determine the rate. Now let's talk about our abnormal rhythms. And the first set we're going to talk about is abnormal sinus rates. The first of which is sinus bradycardia. This is a fine rhythm. There's really nothing wrong with sinus bradycardia. Some people, when you're sleeping, you're going to get a lower heart rate. Athletes tend to run a little lower. Honestly, as long as your heart rate is, usually greater than 50, we're fine. When that heart rate starts to fall less than 40 beats a minute, we do get concerned, even if it's at rest. We're going to go through our checklist here. There's a P for every QRS, P for QRS, P for QRS. When we measure this PR interval, it's 0.12 to 0.20. Our QRS is 0.06 to 0.10. And our rate for this is going to be somewhere less than 60, less than 50 to 60. 60 is normal. So once we start dipping below that, we call it a sinus bradycardia. And so if you count the boxes between these 2 points, you'll see that the rate is lower. Sinus tachycardia is the opposite. It's just too fast. When we look at it, the rate is greater than 100. So the number of boxes between those 2 points is going to be less, and calculate that rate out for a minute. Again, we are going to see a P for every QRS. They're hard to see when they're going very fast, but they are there. I'm marking them. The PR interval should still be 0.12 to 0.20. It's probably going to be closer to 0.12. And the QRS is going to be closer to 0.06 because they are going so fast. Sinus tachycardia is not terrible. You'll see it when you are maybe running a fever, maybe when you are engaged in physical activity. Um, it's not great long term because it does kind of tire you out, but it is not all that abnormal as far as a dangerous rhythm unless it's continuous. Sinus arrhythmia, if you just look overall at this picture here, you can see variability. And what happens with sinus arrhythmia, again, it's not all that awful of a rhythm. A lot of times we see this in children, or we can see it vary with respirations. When we breathe fast or take a couple deep breaths, it's going to speed up the rate. If we hold our breath, it's going to slow down. But you see some faster beats and some slower beats here. If you check at this rhythm very closely, you'll notice there is a P for every QRS. The PR interval is 0.12 to 0.20. The QRS is 0.06 to 0.12, but there is variability. So if you count the rate from here to here, it's going to be a different rate than if you count from here to here. So it doesn't work out well to count just between two. You actually have to count a longer strip and actually count the number of beats for a minute or 30 seconds to calculate the actual rate because it is varying. Let's move on to sinus arrest. Sinus arrest, also known as asystole. What we have here is a flat line. There is no P, there is no QRS, there is really no electrical activity at all. There's no cardiac output, no rhythm. This is bad news. You are not making any progress at this particular point. The patient has no cardiac activity. Now let's talk about rhythms that start at a different site of impulse. We're actually in this category going to talk about ones that start at a site other than the SA node. These particularly are going to start at the AV node or the AV internodal pathways. These are the first few we're going to talk about are our atrial dysrhythmias. So the impulse starts in the atria, but not at the SA node. Because the SA node is the faster of the pacemaker sites in the heart, these particular rates are going to be a little bit slower. So they're going to be usually not more than 100. The first one I want to cover is a PAC, or a premature atrial contraction. This is one extra contraction. What we have here, and the kind of this highlights the actual PAC. What we have is a atrial contraction that is occurring too soon. If you look, it happens just a little bit quicker than it needs to happen. And what we have is an extra P wave, and because the atria has given us an extra P wave, it's causing an extra contraction, and so it's just a little bit early. It's really not a big deal. They occur very occasionally. Unless you're having them all the time, it's not something that we're terribly concerned about. Now, atrial flutter is a very characteristic pattern. If you notice here, this little sawtooth pattern you're seeing here, and that is very characteristic of atrial flutter. What's happening is the atria are kind of fluttering or contracting in this real kind of regular rhythm, but it's too fast. If you notice, you do not really see P waves. You're just seeing that atrium kind of contracting on some type of kind of predetermined rhythm. So there's no P wave. If you look at the size of the QRS, it is normal. So what we're seeing is this rapid atrial rate. This atria is contracting very, very quickly. Our next one is atrial fibrillation. This is very common. So you must be able to recognize this. With atrial fibrillation, again, there is no P wave because it's starting not at the SA node, but it's actually starting down at the AV node. What we're seeing is the atria are quivering. They're just kind of shaking, and you see this shakiness going on between the QRSs. Because there's no P wave, the QRS doesn't know when to go, or the ventricle doesn't know when to contract. And so we really start to see this irregular rate going on because that atria has really not got a consistent contraction. It's just kind of shaking. And so the ventricles are just kind of randomly going, and is going to be a little bit of a problem for us. Your P wave or your atrial contraction actually is important in producing some of your cardiac output. So when we have atrial fibrillation, we actually lose this thing called atrial kick, and it reduces our cardiac output by about 25%. So we've lost a good 25% of our cardiac output, which is going to make you short of breath, maybe a little dizzy. You may not be able to do as much physical activity when you're in atrial fibrillation. The other thing is when we have this quivering going on in the atria, blood is not consistently leaving the atria. And so blood may be stagnant and you may have some stasis of blood in the atria. The problem with this is it increases your risk of clot development. And that's not a good thing because you don't want to have clots because if you do contract and throw out a clot to your body system, it tends to want to go to your brain and cause a stroke. So AFib actually increases your risk of strokes. So patients with AFib usually have to take what we call blood thinners or anticoagulants. Again, the rate is going to be irregular, so you can't really count it from QRS to QRS. You really need to look at a longer strip to make sure that you get an accurate rate. Now let's move into our ventricular arrhythmias. These are dangerous. Okay, so what's happening here is the impulse is generating now from the ventricle. So it's skipping the AV node, the SA node. And because it's skipping those, the QRS tends to not be normal looking. It tends to be wider and bizarre looking in all of these ventricular arrhythmias. The first we want to talk about is a PVC, which is a premature ventricular contraction. A few PVCs here or there is not a huge deal. Everybody has them. It's when they're every other beat, every third beat, or they are continuous. That's going to be the issue. But what we're seeing here, this arrow is identifying, is this beat here is a premature ventricular contraction. What's happening, this is the ST segment here. This is the QRS. And so this right here is the T wave or the ST segment from the prior beat. There is no P wave. And on top of it, your QRS is very wide. And it's a little bizarre looking. So in this particular case, one of these every once in a while, not a huge deal. However, this particular beat that circled did not perfuse and did not deliver any blood to the body. So blood got delivered to the body here, it got delivered here, no blood, no blood. The next blood is here. So you would actually not feel a pulse with that particular contraction. This pause is not a huge deal if it's occasional. Our next is VTach, or ventricular tachycardia. This is bad and dangerous. This is a lethal rhythm. You cannot maintain consciousness with this. Actually, after several beats, you will lose consciousness, so that's a problem. What you're seeing here is a rate that's faster than 100. We would, if it was one, we'd call it a PVC, but because there's more than three in a row, we're calling it a run of VTach. So when you have three or more PVCs in a row, we now call this VTach. After several beats, you will lose consciousness because remember, there's no cardiac output. They do not perfuse or provide a pulse, and you don't feel anything with that. The QRS is too wide, it's bizarre looking, and there is no P wave. You need to be able to recognize this because it is a shockable rhythm, and you do need to call a code and get a crash cart. VFib, believe it or not, is worse than VTach, although VTach isn't great either. What VFib is basically VTach that has really decreased in amplitude. What happens when you go into VTach or VFib, as these quivering or these kind of shakiness to this rhythm gets smaller and smaller and smaller, it gets harder and harder and harder to shock or recover from. So if it starts out like this and then it gets smaller and then it goes to a flat line. Okay, so it usually doesn't go quite that fast, but this is harder to deal with than this or this. So the more amplitude you have, the easier it is to manage this and get the patient back into a normal rhythm. What's going on with VFib is that the ventricles are quivering. Remember AFib, the atrias were quivering, but the ventricles were still doing their job, and the ventricles put out your cardiac output. In this particular case, there's no cardiac output, there is no QRS, and there's no P wave either. This is bad. You need to call a code, get a crash cart. Now let's move into our category of conduction pathway disturbances. Now remember, these are things where the conduction is being either delayed or altered as it moves down through the heart muscle. Our first group is going to be AV conduction disturbances. These are delays and disturbances as the impulse travels downward through the AV area or from the kind of the AV node. These are often called heart blocks. Our first AV conduction disturbance is first degree heart block. First degree heart block really is not all that bad. It may or may not be treated as long as the patient seems to be tolerating it okay. When we look at first degree heart block, the one thing we notice is that the PR interval is long. It is greater than 0.20. So what's happening is the atria are contracting, but it's kind of getting stretched out and delayed, and it's delaying when the ventricle contracts. So it's kind of slowing it down through the AV system. We do notice, though, in first degree that every P wave has a QRS, which is helpful. When you measure your QRS is normal. So really what we see in first degree heart block is just a prolonged PR interval. It's fairly, the rhythm is fairly regular, and often we don't treat it. Our next thing is second degree heart block. Now, there are actually two types of second degree heart block. There is second degree type 1 and second degree type 2. The thing that second degree heart block has in common is that some of the P waves are not conducted to the ventricles, but they're conducted in different patterns depending on if it's type 1 or type 2. So what you're going to see is some P's will not have a QRS. And the difference between type 1 and type 2 is the pattern with which this occurs. Type 1 is a progressive lengthening of the PR interval, and then a P drops, and then it starts over. So let's start it here. You have a P wave and no QRS, so that's a dropped beat. And then the pattern starts again. Short, longer, longer, drop beat. Short, longer, longer, and then this one would be a dropped beat. So really what you have here is a pattern with the P waves of short PR interval, little bit longer PR interval, even longer PR interval, and then a dropped beat. So it's a pattern. So now let's talk about second degree type 2. What we have here is some dropped P waves. You go back up here, remember some P waves are not conducted to the ventricles. But what you're seeing with these is it's not as much of the short, long, longer pattern. You see P, no QRS, P, no QRS, P, QRS, P, no QRS, P, QRS, P, QRS. So it's dropping beats, but not in a pattern. And now we'll talk about third degree heart block. With third degree, our biggest problem has to do with that there is no communication between the P wave and the QRS. The P wave or the atrias are doing what they want to do. The ventricles or the QRS is doing what it wants to do. They're each doing their own thing and they're not communicating with each other. What you really should see is P, QRS, P, QRS. But you're not seeing that. Here's a P, here's a P, here's a P, P, here's a P, P wave, P wave, P wave, P wave. And then you got a QRS, QRS, QRS. And there's no coordination between the two. They're just doing isolated problems or their own isolated beat. In this particular case, this is trouble and patients usually need a pacemaker. With that pacemaker, we can actually pace the atria and the ventricle to coordinate that for the heart. Our last intraventricular conduction defect that I'd like to cover is what's called a bundle branch block, or a BBB. A bundle branch block is really a delay or slowing of the impulse through the intraventricular bundle. So what's happening is the heart rate is actually the electrical activity is getting stretched out as it moves through the ventricle. And so you start to see this stretched out QRS. And you see a wide and bizarre QRS. And here's a nice picture of that here. You still have your P wave. The atria is doing its job and it's doing it very nicely. The PR interval is fine, but the QRS is too long. It's greater than 0.12. Now, a bundle branch block can be a left or a right, depending on which ventricle is damaged. And really, a common cause is a myocardial infarction. Commonly results in a stretching out because if there's damage to the ventricle scar tissue, then the conduction gets delayed as it moves through that. So MIs commonly cause the bundle branch block. So as we wrap up, I'd like you to think about a few things here. First of all, what are the reasons or the mechanisms with which dysrhythmias occur? Remember, we talked about maybe failure to repolarize. We talked about maybe a triggered event where the impulse is maybe generated too soon or not in the right time frame. We talked about sometimes the pacemaker um, actually comes from a different location, or the beat starts in the wrong location. And we also talked about conduction defects, where conduction is delayed or slowed or abnormally conducted through the heart. And remember, what happens to your cardiac output and your blood pressure when there is a dysrhythmia? Well, your cardiac output decreases, your blood pressure decreases, and you really do not perfuse your body. What are your common causes or etiologies? Hypoxia or ischemia to the heart muscle, maybe from a heart attack, electrolyte disturbances, specifically potassium and calcium, maybe trauma or inflammation from MI, maybe even drugs, whether they be prescription or illicit. And how does a pacemaker help a dysrhythmia? Well, a pacemaker actually helps start the beat. It delivers the electrical impulse. So if your electrical impulse is not being delivered or it's not being delivered at the right time, the pacemaker can step in and do that. And when it delivers the electrical impulse, then the heart can mechanically contract. And why would anticoagulants be ordered for a patient with a dysrhythmia? In particular, which one? Well, atrial fibrillation for sure, because remember, when there is fibrillation going on, we have stasis of blood and the risk of clot development, which can cause stroke. I think that about sums up our most common dysrhythmias or arrhythmias. It should get you started to go out to the clinical setting and deliver that awesome patient care that you do. And I know you're going to be a great nurse because of it. Have a great day.